I would be talking mainly about the evolution of various positions. Supine in itself is a position, but there has been an evolution in the supine position as well. So why these evolutions happened and what are they is what I'm going to really focus upon. The aim of this presentation at the outset, let me tell you, is to highlight the importance of learning the skill of supine PCNL, which for reasons of undeserved ignorance has been buried in oblivion for almost 3 decades. Now, even if it does not appeal to your conscience, it is not a wasteful weapon to have in your armory while you are striking blows to the stones that you come across. So all of us know, and we have been told repeatedly, that Fernstorm and Johnson have devised this technique of percutaneous stone extraction. And probably they started with the prone position because there were no ultrasounds or CT scans in those days to actually guide them to the changes in the organ positions which happen with change in body postures. So they took the apparently safe approach, wherein they had probably known the lumbotomy approach to the renal pelvis, wherein the kidney is supposed to be nearest to the skin. And that's how this technique went on being performed in the prone position. Now, the question arises, 1976, the prone PCNL came, 1987, the first publication on supine PCNL came by Dr. Valdivia. So just with a gap of 10 years until date, now it's almost 40 years for the prone position and 35 years for the supine position. Why were we enamored into ignorance for 3 decades? Why were we not actually considering the supine PCNL at all? Well, the reason is the serendipity, the innovations in renal access material, the optics, the radiology, and improvements in lithotripsy devices, and the vehicles of all these, that is the master craftsmen that we have on the other side of the screen. Sorry if I have missed any, which carried it forward and prodded even all of us to do so. They all overwhelmingly contributed to the prone PCNL. And we all saw more and more laurels being brought about by this technique to the field of urology. They made it the most popular technique available for treatment of the renal calculi, and hence all the competition that existed during that time, it paled and failed to attract any attention. Moreover, the availability of mentors made the skill acquisition very easy for all the learners. So the learners also started and went on performing it in the prone position. The success of the results attracted more following. The success was very profound, and so everybody just went on learning it. The proficiency in the art enabled each one of us to climb new frontiers every passing year. And the extension of reach within the kidney, from within the kidney to the upper ureter, we started doing from one calyx to the other calyx, from other calyx to the third calyx, single puncture, multi-puncture prone PCNL. And then from the renal tract, we started approaching the upper ureteric calculi also. So we almost obliterated the need of pyelolithotomy and subsequently even the anatrophic nephrolithotomy. So the entire need for open surgery was obviated by the technique of prone PCNL. So this gave us a feeling of a very high from where nothing else was noticeable. And this supine PCNL went into total ignorance. The limitations of the prone position with respect to individual setups have been told by Dr. Chawla. The commonest all of us face as beginners or as practitioners of individual nursing homes, practitioners of urology in individual nursing homes, is the limitation of staff available for assisting. The prone position takes about 8 people for the positioning, proper positioning. Anything short of this 8 would lead to a serious damage to the patient. So this is obviated in the supine PCNL, which probably requires no additional personnel during the procedure, just a nurse, assistant nurse, and a technician for the manipulation of the CR. Coming to the positions that have come over all these years, all these 3 decades, 1987, this is the timeline. And with each passing year, with each passing position, there was some or the other modification which was proposed, either it proceeded with advantages, or it was discarded because of disadvantages. The originator of the technique was Mr. Valdivia, who did it in a supine position, complete supine. The legs were stretched. The ipsilateral arm was resting on a support across the chest. The legs were lying straight on the table. He defined the area of activity available that was between the posterior axillary line, the costal margin, and the iliac crest. He divided the area of puncture to about 2 to 3 centimeters behind the posterior axillary line. He devised it as the safest area to puncture and create the tract. That was the biggest contribution, and he has a very detailed description of his technique in the 2-3 papers that he published between the time period of 87 to 90. And one of his papers was what actually guided me also when I did my first case. I'll come to it later on. Now, why there were modifications to the original technique? They were probably aimed at improving the ease of puncture under the image guidance. Most of us, we do it under fluoroscopic guidance. So the ease of puncture is what guided for various modifications. The operative field availability, people felt the operative field available was very small. So some of them would tilt the patient more or do something else to increase that field. Ability to make and dilate multiple tracts. Just like in prone PCNL, multi-tract supine PCNL was also considered, and that's why some of the positions were devised accordingly. Ease of combining retrograde intrarenal surgery. Now, this is something which has probably appealed to each one of us in the last 5 or 6 years when Flexi-URS and other things came into use, and simultaneous usage was something which was asked for. And prone PCNL was a big, big obstacle to this. And that is why more and more webinars, more and more seminars, more and more interest is developing into this technique. Otherwise, I remember in 2014 when I had published this, I had spoken about this in one of the conferences. One of the titans of prone PCNL all over on the national front, he was surprised, and he said he probably didn't know about this technique. I was surprised because so is everybody who practices this art. It's really a very beautiful technique and did not deserve to be, neglected for all this while. There was a slight variation to Valdivia position by his followers who started doing it with a flexion of the lower half with access to the external genitalia also. Goldakao modification was one which probably stayed for a very long time, and it came to be known as GMSV, or the Goldakao modified supine Valdivia position. He described it in the 2007. When he made it a slight lateralization of the supine position, the contralateral leg was fixed and flexed. The ipsilateral was slightly extended and resting on a support, achieving a modest lithotomy position. Intermediate supine lateral position was there, and a 3-liter bag was kept in the ipsilateral flank. So more or less a Valdivia urea position with slight difference in the lower half of the body. The Siam position in the Goldakao supine remains the same as in the prone positioning also. It allows an access to simultaneously the entire urinary tract. That is one very big advantage. The supine position 3 is the Bart's modification of the Valdivia supine position. Now, Bart in 2007 introduced this position wherein he tilted the patient to almost 90 degrees for a greater area of manipulation. Now, this area increased, but what happened with this was the kidney moved medially and anteriorly. It became more mobile, and so this position was probably did not go a long way with people. It did not find much support because the puncture and the manipulation makes it a more difficult procedure, and the greater torque required to do all these things holds the risk of damaging the renal parenchyma, and that is the reason for increased bleeding also. So this did not go for a very long time. Then there is a very big series by Mr. Falahatkar. He has multiple papers on supine PCNL, and he does it in total supine position. He doesn't do even a bit of inclination of the flank, just that the patient is pulled more laterally. So the disadvantage of his position is that there is overlapping of the flank on the side of the side branch of the side support of the table. So many times there is an overlap, and that's why the puncture becomes a bit difficult. However, that is a very temporary thing, and probably it can be managed by slight movement of the patient, and a great deal of support and success can be achieved through this position also. So these are the limitations. It allows limited space for planning the renal axis because the flank is not elevated. It may result in the reduced ability to maneuver the nephroscope because the area is again reduced. And there is no readily available retrograde access to the urinary tract because the legs are stretched. They are not placed in the lithotomy position. Now, Bart's position was later on modified into a flank-free position. So the rotation, which was 90 degree in the earlier Bart's flank position, came to be reduced to just a 15 degree. You can see here just a small pad is placed under the ipsilateral pelvis, and a larger 3-liter bag is placed under the torso. And the rotation done is just 15 degree, and a wider area becomes available for manipulation. The ipsilateral leg, again the leg positions, the ipsilateral leg is relatively extended, and the contralateral leg is relatively less extended with a more abduction. The kidney lies in a neutral position as compared with the other positions, and therefore is the likely displacement of anterior, as in the original Bart's position, is very less. Salient features are it allows easy percutaneous access under fluoroscopy because the tilt is just 15 degree, provides a larger space for placing and creating multiple tracts. Kidney lies in a fairly neutral position. The fairly horizontal tract allowing the low intrarenal pressures. The horizontal tract, because it becomes horizontal, the fluid continues to flow outside rather than accumulating inside and increasing the intrarenal pressures. Allows the RIRS in a position of relative familiarity because the patient is supine, and the lesser torso rotation is only 15 degrees. It makes it more comfortable for the patient also. If you are doing in a regional anesthesia, patient also feels very comfortable. Now this is the semi-supine position wherein the contralateral leg is flexed below the outstretched ipsilateral leg. Not much of significance to this because just one paper has been found in the literature in this position. The flank-free modified supine, again, a similar procedure where there is just a tilt of the torso upwards. The flank is not supported at all, and the contralateral leg is flexed below the outstretched ipsilateral leg. Oblique supine decubitus. Again, this position is preferred only in obese patients, wherein the fat is supposed to be displaced away from the operating field, making the operating field available a bit more. This is Giuseppe Giusti, the double S position. Why it calls it double S is not explained in the paper, but what the position says is the legs are secured independently, they are outstretched, they are not flexed, they are slightly abducted at the hips, but they are straight. The buttocks lie at the edge of the table and the external genitalia are exposed for easy retrograde access. Ipsilateral arm is placed across the chest and is fixed to the wrist of the opposite limb. The contralateral arm is outstretched and straight. The thorax is slightly tilted to about 30 degree. He even suggests measuring the angle of inclination with a protractor, which comes in the form of a mobile app, EXA mobile app, which is available on the Play Store. And latest in the list is Mr. Guido Giusti. He has a big presentation, big series also, and he has a very good tutorial webinar available on the YouTube also. Now the salient features of this position are the ipsilateral leg is straight and the flank is elevated on longitudinal supporters. The entire flank is supported on longitudinal supporters, which raise the flank to about 15 degree. There's a single, the advantage is that a single draping can be used to the entire procedure. He claims better ergonomics and a shorter operative time. Plus, he also says it's a simultaneous bilateral surgery supine PCNL position. He labels it as SBES. So supine bilateral PCNL is what he calls it. And he says in tandem, you can do a PCNL, supine PCNL here from this side. And if suppose there has to be an RIRS to be done on the right side, another surgeon in tandem can do the RIRS on the right side also. Now, various supine PCNL people claim the same thing for the same side also. Bilateral access and dealing with multiple stones or a larger stone burden. It can be done on the single side also, but he claims you can do it with two surgeons on two different sides also in the same sitting. The C-arm positioning, as Giusti elaborately describes, is almost the same as in the prone position. The advantages will be told to you later. Target calyx is at 0 degree. Movement of the kidney with that of the needle signifies the correct plane. So initially when you puncture, you do it in the 0 degree plane. Identify movement of the kidney. If the movement of the kidney moves with your needle, you are probably in the right plane. And once you puncture the calyx, the urine flows out with gravity. You don't have to suck it. But if urine doesn't come out, you probably are missing the plane. In that case, he advises triangulation. Now the triangulation is done in the craniocaudal direction. The C-arm is moved towards the head of the patient. And if the needle moves below the pelvic alyssal system, the puncture is too anterior. So you should modify it accordingly. If the needle moves above the pelvic alyssal system, the puncture is too posterior. So accordingly, you can move it a bit anteriorly and repuncture. Conclusions overall is that there is no consensus on the best position amongst the supine positions. One supine position does not fit all. The urologist must familiarize himself with all the positions so that an appropriate position may be used for each patient according to the morphology and the stone burden. Now, my mentor, I had no mentor for this technique, but there was definitely a Tor-Mentor. So Tor-Mentor is somebody who torments you. And this is one patient who was a obese female patient. She had a solitary kidney with a stone in the renal pelvis. She was waterlogged, presented to me with ARF, could not be given anesthesia because of a poor cardiac function. So I was reminded and I took my first step towards doing a PCN in the supine position, which I could very successfully do. And within 24 hours time, the patient became acceptably deflated.
Sorry for interruption. I am getting many messages that the audio is not clear. So it is a request to the organizers to kindly look into and please see if the audio becomes clear. Thank you. Sorry, Dr. Sanjay. Carry on.
No, it's okay. Okay, I'll just move closer to the mic. Maybe that will improve somewhat. So the patient, this patient I could subsequently operate very easily, and I subsequently started doing supine PCNL. Then in 2012, I submitted this 100 patients publication, which was published in the Euro Today International Journal in 2013, wherein I had a good experience with 100 patients. And this is a small run through of the technique that I follow. So this is a renal pelvic stone in an equally obese patient. This is the armamentarium that I use. It's a simple thing. Marking of the field. Now the kidney was a relatively low-lying kidney. So when I started the puncture, I found that I could reach through the subcostal area into the superior calyx. As you can see here, I punctured the superior calyx, dilated the tract, and you can see how easily and how comfortably the lie is of the nephroscope also. The maneuverability of the nephroscope is also seen. We have ample space available, and I could achieve a very good stone-free rate in this patient. The lie of the sheath is such that the fragments tend to come out rather than go and displace and create problems for us. They don't go here and there, they come out. So that's another advantage. That shows a complete clearance. And after the procedure, once we take out the sheath, a 5 minutes compression is all that is required, as we do in prone PCNL. So now how I used it, having known both prone and supine positions and not having to move my C-arm and other equipment from this side to that side, whenever I had patients with bilateral stones, I used to do the right side by supine PCNL, and the left side I used to turn the patient and do it with prone position. So the number of staff required, number of manipulations of my equipment also reduced, and the durability of equipments improved. And this is how I was able to create a multi-track PCNL also through the supine approach. And I found it a very handy technique, very useful. Thank you very much.